pain physician who cares for those who are suffering from pain, and I'm a researcher who's focused on making discoveries and the mechanisms of what leads people to go on to develop chronic pain and then translating those into safe and effective therapies. In this discussion, you should know where I stand on opioids, and I'll share with you. I'm not pro-opioid. I'm not anti-opioid. I'm pro-patient, and I hope that'll be a theme throughout this entire discussion. The fact that we have a prescription opioid epidemic in this country is indisputable. This has gotten the attention of our president, who recently commented silently.
Killed.
Let's try that again, shall we? Because I know that President Obama actually has something to say.
It's important to recognize that today we are seeing more people killed because of opioid overdose than traffic accidents.
That was followed up by the CDC guidelines that put forward a 12-part plan on how to reduce opioids in this country. Most recently, our own Surgeon General, Vivek Murthy, put out a letter to every single clinician in this country imploring them to join him to band together to reduce this opioid epidemic. The merits of this are unquestionable. We can all get behind it. I've seen firsthand the effect of addiction and overdose deaths in my family, in my patients, and a toll on society as a whole. But we don't want to forget two very important parts of this. One is the unintended consequences of these very aggressive actions that we're starting to see come out, and two, one of the major drivers that is behind this. With regard to the unintended consequences, what we're seeing now are patients who have been behaving themselves and using their opioids as prescribed, being discharged from physicians' clinics and told to go find their opioids elsewhere. I oversee one of the largest comprehensive pain centers in the country, and just this last week, while in the clinic, there was a suburban housewife who was discharged from a clinic on a small amount of opioid, told to find another doc. She ended up on black tar heroin. That's tragic. We can do better. The second part of this is to understand one of the primary drivers behind what's causing this opioid epidemic, and that's the problem of pain. We have a public health crisis of pain in this country. It is an astounding problem. How big is it? Well, the Institute of Medicine report on pain that came out in June of 2011, which I was honored to serve on, we characterized about 1 in 3 Americans have chronic pain. Everything from people who self-manage at home, like my father, to people who have high-impact, catastrophic pain, and everything in between. We realized that also it is of huge cost to our country, over $500 billion a year, more than diabetes, heart disease, and cancer combined. That also, through our science, we've learned that while pain is often a symptom of another condition, it can, when it's persistent, become chronic and a disease in and of its own right, one that fundamentally alters the entire nervous system and every other system, much like diabetes does. We've learned that pain clearly reduces quality of life, but we also put forward that it's highly undertreated and that there's disparities in how it's treated across this country. And probably one of the most important messages is that we need better quality data. The quality of the data that we have on pain is just terrible. The EMRs, which we've looked to as our saviors, have failed us because by and large they were developed as billing platforms and scheduling platforms. We need better quality data. And so as a follow-up to this, as a follow-up to the Institute of Medicine report, which was a 30,000-foot view of where we are and where we need to be, we developed a national pain strategy. And I was honored to co-chair this with Dr. Linda Porter from the National Institutes of Health. We brought together 80 national experts throughout the country, and we took on these 6 major areas within pain across our entire country's needs. Population research, again emphasizing the need for quality data, prevention and care, disparities, which cross-cut all of the working groups. Service and reimbursement to drive home the point that we need to better reimburse for the treatments that we know work. Professional education, improving the knowledge and competencies of everyone who cares for people with pain. And then last and perhaps most important, public education, to get the message out that pain is a big deal. And also to make sure that our opioids are being safely handled and safely prescribed. Now, I'm going to focus on population research because I'm going to bring this back to home now, and we're going to talk a little bit about what we're doing here at Stanford to help address the National Pain Strategy and answer its call. And so what we're doing is we're focusing on the data issue. In the Institute of Medicine report, better quality of data. National Pain Strategy, better quality data. In a recent 12-part series from the Institute of Medicine, they called for the development of learning healthcare systems. These informatics platforms that bring together science, informatics, incentives, and cultural changes that end up being aligned for continuous improvement and innovation, that take the data from the clinic, use it for research purposes, and also for using it for the patients. The problem is, pain is a really, really complex problem. So there's not going to be a quiz at the end of the session on this. This is a little bit of the shock and awe slide, just to impress upon you just how complicated pain is. It is, by its definition, a biopsychosocial disease, one with many components that interconnect. And so how we address this here at Stanford is through the development of CHOIR, a collaborative health outcomes information registry, which serves as an open source, open standard, highly flexible, and free, my favorite four-letter F word, treatment registry in a learning healthcare system. And so we use this for clinical care for every single patient that comes into the Stanford Pain Center, and we're also using this afterwards for research purposes. We use this to track patients over time, to figure out what works for whom and for why, and we're starting to get into this for real-world clinical trials. We get a very comprehensive phenotype, a detailed description of every patient across all aspects of their physical, psychological, and social functioning and global health. We've developed computer adaptive testing models through the work of Dr. Ming Cao that reduces the burden on the patient so that we can capture this information in just a few minutes. And then we also leverage the NIH Promise system, which is a $120 million investment into recasting all patient-reported outcomes, which allow us to do comparative metrics. What I mean by that is when we characterize a patient here in Palo Alto, and we know what their fatigue and their sleep and their physical function and their pain interference is, we can directly compare that to somebody in Gainesville, Florida, or in Wisconsin. We looked at what had failed in the past, and looking across the country at these platforms, what fails is lack of buy-in. These systems fail because they can't get buy-in from people. And so we worked on a system that directly inserts into the clinical workflow and has very little to no burden on it. We provide point-of-care decision-making for the docs so that they get feedback, so they're invested in this platform, and so that they can make decisions for their patients. At this point, we've collected over 20,000 individual patients, 60,000 longitudinal data points, and I will share with you that it has fundamentally changed the way we care for patients at Stanford. Without quality data, we are all just a bunch of docs with opinions. That's it. At this point, we're now practicing in an outcomes-based model. I mentioned that we're giving back, and so the way we give back is we do automatic note generation. We pull the data from CHOIR, and it generates a clinical note that goes into the electronic medical record. And in the opioid aspect, we've developed features and tools, modules that can help predict whether somebody is at risk for developing chronic pain, and we can also develop opioid tapering schedules that are focused on particularly primary care, so if they do want to wean somebody down, we can do it in a safe, compassionate, and comfortable manner. The goal for this is to develop research quality clinical data. What do I mean by that? Very simply, we want to turn our clinics into research labs. We want to have high quality data from every patient and every patient encounter, and to be able to make that data actionable. Something that will inform us in clinical care, but also will guide us in our research discoveries that will loop back and inform us in clinical care. I'm going to give you a sample of just two of these studies that we've done. These are across many, many that we've now done. This one was led by Dr. Beth Darnell, who has a passion for this area of sex differences in pain and also in opioid prescribing, and also in this construct called catastrophizing, which is a cool name, but really what it means is you have rumination, these repetitive thoughts about your pain, you can't get your mind off of it. It leads to negative amplification, and also you have a sense of loss of control over your pain. And she asked this question, are men and women different? Well, of course they're different, but how are they different? It turns out that if you are a man, you are more likely to be prescribed an opioid if you have high pain intensity. That's this heat map here. If you're a woman, you're more likely to be prescribed opioids if you're high in pain catastrophizing. Now, what's also cool about this is that we can lump all these thousands and thousands of highly detailed data, and we can use advanced analytic approaches that you couldn't use in the past, where we were stuck with linear models. And using, in this case, a general additive model, what we learned is the following. We usually are focusing on that area down in the lower right on pain catastrophizing, these severe ranges. And that's what we've been reporting. That's what people have reported for likelihood to be on opioids. But what we're now learning is subclinical ranges of catastrophizing. Subclinical ranges of emotional distress are very likely to lead to somebody to be on opioids. And we need to pay attention to this range also. I've heard throughout this meeting the importance of social interaction. It keeps coming up over and over again. So I pulled out and put this recent study and that Dr. Sturgeon just led in our group. And let me walk you through this network diagram that he did. We all know that if your pain goes up, your physical function goes down. And that leads you to become upset, depressed, angry. Well, what we've also learned by doing this model in a comprehensive way is that that model is completely subserved by your satisfaction with social roles. What I mean by that is it's actually that your pain goes up, your physical function goes down, and it is your inability to interact with your friends, with your neighbors, with your loved ones, and leads to a decrease in your social functioning. And I'm seeing some nodding heads here. That's what leads you to become depressed and angry. And so now we have developed interventions that are specifically targeting this social functioning role. I'm going to switch gears very briefly here and talk about how chronic opioids often starts. It often starts with an injury or surgery. People being put on opioids and then persistently on them. And so this effort led by Dr. Eric Sun in our group looked at 600,000 patients. We just published this in JAMA Internal Medicine. The bottom line there are for people who didn't go through surgery. The other lines, the bars, are all the different surgeries that he analyzed. And what we find is that surgery is a big risk for your being on chronic opioids afterwards. And there are a number of risk factors involved with this. We've spent the last 7 years collecting 500 patients here at Stanford and deeply characterizing those risks. And what we've learned is that what you bring to the operating room table often has more to do with whether you're going to have chronic pain after surgery and use opioids after surgery than the pain itself. Now, I mentioned we spent 7 years collecting 500 people and used a lot of the NIH money. We've now put Choir into this environment, and within 3 weeks, we collected the same amount of data. That's the power of these platforms. So let me close out here with a couple points. We've got an opioid epidemic. We've got a crisis in this country. We need to do something about it. Like every other epidemic that we faced in this country, we are going to solve this problem, and we're still going to have chronic pain when we're done. So why not work together and solve both problems together? And in doing so, what we're going to need is better quality data, and we're going to need these types of informatics platforms to be able to capture that quality of data and put it to good use. Thank you.